Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, George Margellis.
George, I feel like it's been ages since we've seen each other because so much has been going on, but I actually saw you last week at an event. It was last week, wasn't it?
Absolutely, yeah. It was only a couple of days ago, actually, yes. It feels like forever. I mean, you've been halfway around the world since then, so you've been busy, as I see.
Yes, it has been busy. What have you been up to while I've been traipsing around?
Your exciting journeys over the last 2 weeks, but quiet here. So we've had, after the big ITAC and various other events and the Barcelona event, the only big event we had here in Sydney really was the Australian Healthcare Week in Sydney, which was a good place to catch up with a whole bunch of old friends and new friends. They did have a couple of interesting speakers out from the US. At the end of the day, when we sat around chatting with some of the locals, it was the same old story. Interoperability, standards, models of care, nothing revolutionary, nothing out of the ordinary, stuff we've been talking about for a long time. But I did, the day after that, head off to the state parliament where we were celebrating Greek National Day. So that gave me a bit of a buzz for the rest of the week.
But what do you do on Greek National Day?
Well, the local consul general had a cocktail party, but we actually had on Sunday a march through the streets of Sydney and a whole bunch of kids. Fortunately, my kids are too old, but some of my nieces and nephews dressed in national costume marching down to the Opera House where we had a big concert where we had dancing and speeches and music. So it was quite a festive event.
Wow, that's awesome. Cool. I'd have to check it out. Melbourne probably had something similar. I know we've got lots of Greek people that live in Melbourne.
I think you would have probably been somewhere in the middle of the Pacific or the Atlantic at that stage.
Yeah, I would have been in a plane somewhere, so I've completely missed it. I'm going to diarise it, George, so I can learn next year and hang out with you. Yeah. That'll be fun.
Cool. What's your fortnight been like, Louise?
It has been really crazy. Like my trip to the UK, I was there for 7 nights in 5 different beds, and it was planned, except for the last night where I had to spend an extra night because Heathrow Airport closed for 24 hours. I woke up at 5 a.m. to take a meeting. So I'm looking at my phone, lying in bed at 5 a.m, and I get a New York Times alert saying, breaking news, Heathrow Airport's going to be closed because of a fire. And after the meeting, I rang Ryan, who works in the energy sector and has for years. And I said, I think I'm going to get stuck here. And he's like, oh, no, don't worry about it, Louise. These systems are set up for all of this. There'll be backup generators. And I wasn't flying out till that evening. But yeah, Ryan was wrong. And it turns out there's big investigation happening because there should have been backups, but no. And it caused, I would not want that job, George, having to reroute thousands of planes impacting hundreds of thousands of people all around the world because the airport was closed for 24 hours. It's insane.
You just don't realise what happens like one day in one hub and what it caused. I mean, it was all over the news here and we were hearing about people being delayed weeks, which is what our concern was. They'd be stuck there for a couple more weeks because of the and it wasn't just the matter of getting the planes there, it's then getting the crews there and getting the passengers in the right place and coordinating. But luckily, Qantas did a good job and got you back relatively quickly.
Qantas did a really good job. Yes, hats off to Qantas. Qantas, we would be happy to have your sponsorship dollars on PulsePod. But no, Qantas did really good. Instead of coming back to Melbourne, though, I got rerouted through Sydney and I was going to be in Sydney for work anyway. And because of the delay, so I was like, no, you just have to keep me in Sydney now. Like, do not send my bags to Melbourne or I'm completely screwed. And saw you at an event with the agency, which was wonderful. Came back to Melbourne and then went back to Sydney for the hackathon. So since we last recorded the pod, I've done UK Rewired conference, an event with the agency, and have spent 3 days at the RACGP hackathon in Sydney, which was, it sounds silly, but I want to say it was magical. Like I'm still on such a high. I only got back late last night and the hackathon was just incredible. But it could just be also that I'm sleep deprived after that travel for the last fortnight.
No. Well, I think it's exciting. And the fact that the RACGP is doing a hackathon just shows how far we've come in the last couple of decades because when I first got engaged with the RACGP around digital health, or what, as they called it, e-health back in those days, the meeting they had was actually in Parliament House in Canberra. It was a very formal meeting. We each had 15 minutes to say our piece, which had to be pre-prepared, weeks in advance. So the fact that they're doing hackathons really shows that the sector's really taking on innovation in a big way.
Oh, absolutely. And I was so impressed. We had double the number of GPs that wanted to participate than what we could fit in the room. It was well sponsored. And the sponsors, when you come to a hackathon, they're not just got a little trade display. They're in the rooms with their expertise being mentors, which was just amazing. And I also just wanted to echo your thoughts about the RACGP, because not only is it great that RACGP did this, But the president, the vice president, the CEO, senior staff, they were there all weekend. And you should have seen the GPs. They were so like, oh my God, the president's here. And they got to have photos and everything. It was just so great to have their enthusiasm and literally visibility. It just gave so much love and support to the clinicians there to know that we do want you to look at this and not just accept the status quo and look at how we can improve things for GPs and our patients.
That was Michael Wright.
Yes, Michael Wright.
He seems quite, and like we said, presidents of RACGP go on to bigger and better things. Our good friend, Professor Michael Kidd, has now been appointed as the Chief Medical Officer for Australia. He was RACGP president as well. So it just goes to show
I know.
There are career prospects for GPs, for those kids who don't think that being a GP is an important job.
That's right. And it is a very important job. Everyone got along so well. And what they produced, George, I was so impressed. The team that won was a virtual patient waiting room. Of course, we've all been there. There wouldn't be a Pulse Pod listener out there that has not had to wait for a clinician in a waiting room. As we were discussing all of this, someone from Perth told me, when you need an outpatient appointment, it's for the day. And so you're given instructions to show up at like 8 a.m. or 8:30 a.m. when they open, and they'll see you sometime that day and bring a book. They can't even give you a window shorter than 8 hours. It's just insane. So these guys, they didn't just come up with a great idea. They built something, George. Like they had an avatar that contacts you and says, hey, George, really sorry. I'm Dr. Smith's virtual assistant and he's running late. We expect to be about an hour late, but I will message you as soon as we know more so I can give you a more accurate time window. Feel free to not come into the clinic until I can provide that window for you. And you just think of not just GPs, of course, but specialists, allied health. I mean, that the pressure that could take off the clinicians who don't want to work that way and don't want to have patients show up to their appointment being pretty pissed off because they've had the runaround. So that was one of the solutions and it won. It was very cool.
And you can definitely see scope for how that would help the whole patient experience. Look forward to maybe having some of our GPs as guests in the future and telling us about some of their visions.
I think we will need to, yeah, because all the teams were amazing. So there was a couple that dealt with referral management, but their way of solving that problem was really different. We had people in one of the teams literally coding, like scraping websites, and they created this directory. At the end of the day, there were 90,000 clinicians in this directory. Like they could have just screenshotted something and dummied it up, but nah, they literally built it using a Raspberry Pi. I was so impressed. We had a one dealing with medication supply chain management. Unfortunately, it seems to be happening more often that we go to our clinicians and they go, okay, well, this is the drug that you need. And then they click their system and get told, oh, no, it's not in stock. And sometimes there's alternatives, but sometimes there aren't alternatives. Another group looked at customer relationship management systems. And, generally in healthcare, we pretty much suck at customer relationship management. So we had a team dealing with that, and another one, locum management. So there were two GPs there who are locums, and they showed us the PDF documents that they get, which are horrible. And apparently to get a locum at your practice can cost you upwards of $20,000. And there's no guarantee that person will stay for very long. And so this group created a system. And again, they actually built it. So if you're a locum looking for work, you create a profile for yourself and a little video ad like, hi, I'm Louise and this is my interests and this is what I'm looking for. And I really want to grow my knowledge in this area of medicine or whatever. And then likewise, the practice produces photos and videos and tempts you to say, hey, choose us because we're a great place to work. So I see big things for a lot of these people at the hackathon, George. So I'm sure we will be talking about them again.
Absolutely. Look forward to it.
George, I have another story to tell you and the Pulse Body listeners. Apple AirPods as hearing devices. So we talked about it on one of the pods that you could turn them into hearing aids. Ryan was very excited and bought a pair, but then it turns out we didn't realise that the software wasn't available in Australia. It's finally here, I think last Wednesday, and Ryan raced home from work because it was the one night I was home last week and we had friends visiting from Perth, so we're going out for dinner with them. So we went to Chinatown. The restaurant was so loud. Like even I was thinking, man, I must be losing my hearing. It was so loud. Ryan could hear really well. He sat there all night with his AirPods in and he said it was really good. I asked him to come on the pod and give us like a consumer experience update, but he said no. So, but he said I could tell the story. But yeah, so he's now going to be using them because he used to be a musician. So his hearing is fine in normal situations, but in loud environments like loud restaurants, he can't hear a thing and he's miserable. Then he doesn't even want to go. And yeah, Matt, Apple AirPods have saved the day. So yay, Apple.
Now he has no excuse for not hearing what you tell him.
That's right. That's right.
It's good to hear that. That's a good news story. Yeah, it just goes to show how we've moved from, hearing aids were $8,000 plus specialized investments that needed to commit to. And then now we've got, like I said, consumer technology taking its place. So I think we'll see more and more of that going forward.
Yeah, we will. We should get to our hot topics.
Let's go for it.
In our first story, Bill Gates, yes, the Bill Gates, has caused some controversy and concern when he said recently that AI will replace doctors within a decade. He said that advancements in artificial intelligence will drastically cut down the need for human involvement in many activities, including medicine. And he said that expertise in sectors like medicine at the moment is rare, and it's currently held by medical professionals who spend decades in formal training and a lifetime gathering and using that knowledge. But that progress in AI will mean that high-quality medical advice is going to be readily available to the public at no cost, transforming this exceptional knowledge into something that is actually commonplace. George, what do you think?
Well, look, let me start off by saying that I have a lot of respect for Bill Gates. He's been doing this for a very long time, even longer than me. And my first introduction to Microsoft was back in 1983 when I bought my first IBM clone computer with MS-DOS. So, I've had a relationship with Bill Gates longer than I've had a relationship with my wife, when you think about it. 43 years later, I'm still using a Microsoft product on my desktop. Back then, he was the whiz kid, the wonder child. They always had photos of him looking like a teenager and he did this great deal and he's still doing it. So it's interesting that he's now come into this discussion. I've seen him on stage a couple of times. I've always found him very engaging, very informed. I love the way he speaks. He's down to earth and he does his homework. And back in the early 2000s, his book, Business at the Speed of Thought, was one of those Bibles we used to carry around talking about the potential for innovation. However, his recent announcement about doctors, and he made an announcement about doctors and a bunch of other jobs. So it wasn't just doctors being replaced.
Yeah, teachers was another one.
Teachers, and he talked a whole bunch of things. And it was interesting. The first thing that caught my attention is that he made the comment on the Jimmy Fallon show, which is not where I normally go for my IT news. But hey, just goes to show he's a man of the people and he's talking to people directly.
Well, he's promoting his memoir. That's why, yeah.
He's promoting his new book. I have got that down on my to-buy list. But when I sort of did a bit more digging about it, this wasn't just a flippant comment he made on the Jimmy Fallon show. He's actually been discussing this in depth. And he was recently being interviewed by Arthur Brooks from Harvard University because as an alumni. And they're talking about the role of AI. And he came up with this free intelligence, the fact that AI now makes intelligence available. And it was slightly less sensationalist than his Jimmy Fallon comments. But I have to say, in some ways, and with a few sort of, provisos around that, I think he's right. I think he actually potentially is right. If AI can replace bad doctors or a bad healthcare system, which is what we constantly see happening now, then I'm all for it. Yeah. And what do I mean by that? Well, I mean, if your doctor or your healthcare team is doing today a bunch of expensive tests and a bunch of unnecessary tests and then just reporting to you what the tests tell you and giving you a probability of a diagnosis and saying, here's what you need to do based on the standard guidelines. Well, that's a task that AI may be able to do better than physical doctors. And if that's what your doctor and your healthcare provider is doing now, my strong suggestion would be that you should be looking for another healthcare provider because that is not healthcare delivery. That is the technical part of it. They're getting the diagnosis right, getting the data. That's all very important. But, I go back to quoting my old friend Hippocrates. He says, wherever the art of medicine is love, there is also a love of humanity. And that's what we need to bring into that whole healthcare picture. We need to make it more humanistic, not more algorithmic. And, if AI can replace that technical part of it and then free up the humans in the system to provide the human part of it more effectively, then we've got a win-win. So I don't see it replacing. It goes back to that discussion we've often augment the relationship. But the problem at the moment is that the system is designed in such a way that it technical side and frowns on the humanistic side, and rebalancing that, I think, is where we really needed to go. So if Bill Gates can help us get to that stage, good luck then. Yeah, Bill Gates is in his late 60s, early 70s. He's the sort of guy who's going to need more and more healthcare. So he'll have a bit of scope about what he can do about that.
Yeah, I think he's turning 70. Look, I agree with you. And I think the qualifiers here are important because, you could just say, okay, yes, that is happening. I mean, already my family send me their test results. They know about ChatGPT, but they send it to me because they know that I know how to use those tools. Plus, with my somewhat clinical knowledge that I have, I can help them interpret what these things mean. And they don't feel that they can ask their clinicians that. So I do think that what will change is the business models of healthcare and the practice of healthcare. So I think we are always going to need nurses and doctors and physios and OTs and all of the wonderful clinical professionals we have now. But the way that they practice, what is valued in their professional skills, that is going to have to change. The thing is that it's changing so quickly. I know when Sam Altman and co went and told him in the early days of ChatGPT, look what we've built. And Bill's like, that's pretty impressive. And he tells the story how he told them what it would need to be much better. And he thought they would come back to him in a year or two. And 3 months later, if my memory serves me correct, Sam came back and then they launched it. Like, it was so good. And even Bill was like really shocked at the speed of it. So I think that's where we collectively in healthcare need to keep abreast of these changes and not necessarily embrace them without a filter, but to embrace the fact that change is happening. So what do we need to do to make sure that we still have agency in determining the quality of care and the quality of our work lives as well?
One of the basic tenets of science has been evolution. Adapting is critical for survival. And, doctors, nurses, physiotherapists, occupational, we're all going to have to learn to adapt to this new system. And this is a new paradigm that we're not used to. But if we go back through the history of medicine, there's been adaptations along the way. I mean, up until 1945, we didn't have antibiotics. And yet, once we got them, we changed the way we managed infectious diseases. Up until the early 2000s, we didn't have a lot of the chemotherapies we have now. CAR T is a great example of immunologically driven cancer therapies, which changes. So, the sector needs to adapt. Some of the stuff that stops adapting, regulation, silos that have been working that way for many years, change. But the reality is the technology changes that are out there are major drivers for that. And also, like I said, the individuals who are delivering the care also need to realize that what they signed up for, they've got the choice of changing with it or hitting a brick wall.
Yeah, well, that's right. Well, we will be discussing this topic again and again.
Absolutely.
So, last episode, we were talking about the legislation that is currently in front of the US Congress, which will mean that if they pass it, AI will be able to prescribe drugs.
And the AI lawyer will be able to chase up the case afterwards. So it'll be very interesting journey there.
I know. There's going to be no jobs left for any of us. We'll just all be at home watching Netflix. Okay, well, new story. So if today is your first time joining us in the PosPod studio, welcome. We'd like to revisit previous stories we've discussed on the pod and give our listeners an update. Well, we've got a couple today, and first up is 23andMe. The US-based consumer DNA testing kit, founded in 2006, was at one time the hottest startup on the planet. When they listed on the stock exchange a mere 4 years ago, they were worth $6 billion. And we've previously covered that they have been in big financial trouble for some time, and the CEO, Anne Wojcicki, has tried to buy out her own company unsuccessfully. She's been trying to sell it, also unsuccessfully. And now the liquidators have moved in and millions of people are rushing to delete their data. I fully believe in the importance of personal genomics and it has a big future, but this went so wrong. George, what do you think the lessons are here?
Look, I think there are a number of lessons here. I mean, if you go back to 2000, when Bill Clinton announced at the White House, when they did the first human genome sequencing, how it was going to revolutionize the diagnosis, prevention, and treatment of most, if not all, human diseases, was what the quote was from the launch. It was really exciting times. It triggered a whole industry, and 23andMe was one of the poster childs of that industry. I mean, it was like a great example of consumers meeting medical needs, and this company that sort of made that dark world of genomics, which only professors knew about, available to people by just spitting in a cup. It was a huge paradigm shift. All of a sudden, people had access to information that previously only highly trained pathologists did, and how they did that was amazing. But personally, I'm not that surprised that it's all come to this stage, because it also reflects that 23andMe had one foot in the biology industry and one foot in the tech industry. Was a dichotomy there. Their original goal was to make genetic sequencing available to the masses, and somewhere along the line, they sort of went from that to a business model which looked at how they could utilize the data more efficiently to make extra money, and that became complicated. 2013, they got a cease and desist from the FDA, and I think that was what was sort of the beginning of the end, when they could no longer be a healthcare company because they hadn't gone through the right regulatory processes. So all of a sudden, they had to shift to being a different type of genomic model. And then in 2023, 7 million users' genomes got out there, and that sort of really changed things. So they got two really big body punches. So the fact that they collapsed as a result of that is not in itself unexpected. What is unexpected is that now we have this new dilemma that there's a pool of genomic information sitting on a database somewhere that is on the market. I mean, essentially, when the company gets liquidated, its assets get sold, and someone with a big enough checkbook can go and buy whoever gave their genome to 23andMe, and that's an interesting challenge going forward.
Yeah, it really is. And there's, not necessarily undue concern about that globally. I've been in London, and that I've seen reports everywhere I've traveled on this, and people are wanting to know, well, how do I go about deleting my data? And you can at the moment anyway. But yeah, when you sign up, no one reads terms and conditions anyway. That's why they're designed the way that are, because they know no one's going to read it. But, they say that they won't use your data in these types of circumstances, they're going to protect it, blah, blah, blah. But then, of course, under the liquidators, the data is pretty much the only asset they have, really, and it'll be up for the highest bidder. And liquidators are interested in not making the biggest amount of money. My understanding is just to get some money through the door as quickly as possible and tidy it all up. So, yeah, I think it is something that we need to think about. And we're going to be talking with Janette Hughes later on in the show about people owning their own data and having access to it. So maybe this is something we can talk with Janette about as well, actually. Like, how do we go about making sure that you're always remain in control of your own data?
It does raise the question is that large genomic databases can actually be a public asset as well. So we can actually use for good as well as nefarious reasons. But again, it's that privacy issue and that personal control. Personally, I'd be happy to share my genome if I think it's going to improve health outcomes. However, we've seen some interesting stories arise from the misuse of genomic information in the past.
Yeah. Well, I was on stage at Rewired with a woman from Estonia, and I was so blown away. They are already, because there's like heaps of people in Estonia have already had their genome fully sequenced, and not by a consumer outfit, but, all government controlled. Anyway, and now they're building their medical record to actually include genomic data. So they might be the first country on the planet that ends up that your genomic data is not just there, sitting there, but it's actually used in everyday business as usual healthcare, which is really pretty exciting, I think, because that's when we can usher in the world of personalised medicine. It's going to be better for everybody.
I met a couple of people from the Estonian healthcare system in Barcelona earlier this year too. And yeah, I think the work they're doing there is amazing. And it's interesting how being on the border with Russia has driven their agenda to be digitally enabled and digital first. So I think we really should get some Estonians on board, and their command of English is much better than my command of Estonian. So I think we'll go quite well.
All right, cool. We'll have to open up our Rolodexes and see who we get on the show. Well, now back to Australia for our next topic. That is a revisit. And I checked, I didn't realise, George, I went back through the records and I was like, oh my God, it was our very first episode. We discussed a website that the Australian government had spent $24 million on creating, which was designed to be a directory of specialists and their fees. And it was about bringing transparency to consumers and to the referring clinicians on possible out-of-pocket costs. But pretty much when it hit the headlines last year, it was because no one was using it. The website was a complete wasteland. Queensland. Well, just recently, the health minister has decided to use the levers available to him, and he's now mandating that around 11,000 medical specialists in Australia do provide their fees for listing on the Medical Cost Finder website. George, I believe this change has come about in part due to lobbying from patient groups and also the Private Healthcare Australia, that organisation that represents the health insurance industry in Australia. What do you think? Is this going to be a success?
Well, look, let me first start off with a bit of a disclaimer. Some of my best friends are specialists, and one of the benefits of being a medical doctor is that to date, most specialists actually bulk bill me and my family members when we visit them. So to all my specialist colleagues, yeah, I love yous all, as they would say. But the reality is, Australian specialists have it pretty good, yeah. For most people, they get to charge whatever they want with very few limitations. They've got highly secured positions where they control who their mergers to their competitors are, who gets into their colleges. However, they do deserve to be paid and paid well. It's a really hard slog to become a medical specialist in Australia. Rachel David from the Private Healthcare Association points out that lack of transparency and sometimes that outright price gouging that she referred to. And when I scratched under the surface, I found that some of those things were a bit dodgy. So I think it is a problem. And this making prices public is a great first step. Yeah, so we know upfront. And look, it does stop some people from visiting a specialist. I mean, a standard specialist can be up to $100 plus out of pocket. And for some people, that's a choice between paying the rent or seeing the specialist. So they're having that thing. Hopefully this drives the market driver. Yes, so people. Now, what we don't want is people necessarily shopping for the cheapest specialists available. That's not really the best outcome. So I think, the next stage, and you and I have discussed this many times, Louise, is we really just need to rethink how we use those medical specialists in our country. The current, GP referral model, outpatients, inpatients, there's just so many gaps in the system, and the way we pay for them is bizarre in that we pay them for number rather than quality. So we still really need to have a detailed discussion about what the role of our healthcare professionals is, and really should they be being paid piecemeal, or should they be being paid significant salaries to keep them in the system? I mean, there's a lot that needs to be done there. But the fact that we now know what people are charging, so when you walk in, you don't walk away with credit card shock. Most of them now will take your credit card on the way out. Gone are the good old days when they would send you an invoice, and I remember speaking to some of the old specialists who talked about 30 to 40% of their bills never got paid because people just didn't pay afterwards. But now you can't leave without tapping your credit card. We just need to rethink how the system works.
Well, I also saw, George, and it was quoted by Rachel as well, that there was a survey done by Patients Australia and La Trobe University, and their study of that 5,000 people showed about 1 in 5 Australians don't attend appointments with specialists because they're worried about the costs. Like 1 in 5. And so I think anything that we can do because it's, we're not, again, it will change the market, I suspect, but at the same time, it doesn't have to. It's just really about being transparent so that, like you said, people can avoid that sticker shock.
But often that 1 in 5 will then bounce into the public hospital system and be seen by a much more expensive system, which is providing the same level of care. So, and again, this is where I think things like telehealth will really kick in as well, because it does cost a specialist quite a bit of money to set up a practice and have a receptionist in front and have an office. And sometimes all they're doing is giving extra opinions to the GP's work. So again, understanding how that model of collaborative care works, I think is going to change the game a bit.
Yeah. And actually, one of the teams at the hackathon that was looking at referral management, one of the drivers they said was one of the GPs there, he's got specialist friends and, he's young. So his specialist friends are also young. So they're, recently qualified. And so, they set up shop, spend $5,000 a week on rent, and their waiting rooms, their books are not full because they're brand new. So he was wanting to also help specialists get referrals. People who could refer to them know that they're there so that they're not spending all of this money and, not being able to pay their rent. Now, we've got another story that involves medical specialists, George, and it's an AI story. So we've discussed twice before on the pod that very small study that surprised the world with results that showed that AI was better at diagnosis than the doctor. Now, that story was a very small study, but it blew up, and we covered it twice. It was in the New York Times and everyone was talking about it. Well, a new systematic review and meta-analysis has been published in Nature's Digital Medicine journal, and the authors have looked at 83 published studies. So what did they find? Well, this more comprehensive review showed that there was actually no significant performance difference between AI and doctors. They were pretty much on par. But the difference is, and the article classified them as expert physicians, so it's very American language, but if the expert physicians, they perform significantly better than the AI. So an AI and a non-specialist doctor, basically sort of the same. But if you look at the expert doctors, they do a better job than the AI at this point in time. So look, this is going to be a constantly evolving thing. But given our earlier chat about what Bill Gates said too around the future of medical knowledge, I'm thinking, do we just, as healthcare professionals, do we just keep an eye on this stuff? Or, can we be more proactive in our preparations for this changing fate of medicine and healthcare professionals?
Look, first of all, it's good that journals like Nature's Digital Medicine are now looking into this. So some of those early articles were a bit, let's say, suspect in that they were comparing a doctor on a group within Reddit compared to AI. So, I mean, there wasn't a real demonstration of reality. So, and it's interesting the comment that expert physicians perform significantly better than AI. It's because those expert physicians haven't had AI replacing them in the past, and they would never become expert clinicians in the future because they would never get the opportunity to do so. So it is very cyclical, but it does take me back to, that famous Warner Slack comment. Any doctor that can be replaced by a computer deserves to be replaced by a computer. And I think that's still relevant. We still need to think.
And he said that in 1966.
Exactly. Crazy. So, it just goes to show that these ideas aren't new. What we are seeing is an acceleration of the technology. And, we've seen the huge growth in AI over the last couple of years, although, again, we've discussed there's been a couple of AI winters and there's no guarantee we don't have another one ahead of us. But this AI versus doctor debate just seems to be starting to get a bit out of control. It's like, let's compare one with the other. And there's no doubt that generative AI, it's got access to the entire world literature of medicine, has some diagnostic advantages over the poor old 3 kilograms of brain tissue that sits in the top of each doctor's heads.
And we only use 30% of that.
And we only use the exact same. Yeah. So even if you just go back to our story about Bill Gates, the fact that AI is amazing with diagnostic accuracy is a great tool. However, healthcare is much more than just diagnosis. And again, me, I love my quotes. So William Osler, it is much more important to know what sort of patient has a disease than what sort of disease a patient has. Those are the sort of humanistic things we need to take into account. We can use those AI diagnostic tools to streamline the process. We've often hear about people with rare diseases waiting 2 or 3 years to get a final diagnosis. AI can speed that up. However, we then still need to manage that patient with a disease. And that's where we really need to start thinking about how we integrate AI with clinical care. So there's no longer AI versus clinicians, it's AI with clinicians. And the challenge we face is that we need to break some of our archaic thinking about us versus them and think about togetherness, how we do this as a unit, as a system. And where AI has a real benefit is that it can help us develop that system. At the moment, we don't have a healthcare system. We have silos of healthcare delivered brilliantly by passionate people. But, once they go from one part to the other part of medicine, it starts all over again. So maybe we can start thinking about how we use AI to develop a system. And we need to continue these discussions. So highlighting these studies is important, but then also highlighting where people have taken some of the work of AI. There's lots of avenues we need to go down. And I think we really need to move away from the doctors are better or worse than AI to doctors with AI in a fully developed healthcare system is better than all of the above.
Yes, I completely agree with you. And let's keep an eye on the literature. Hopefully we see more studies like that as well. Because I don't think it's helping the profession as well. Like I'm giving some speeches later in the year looking at what this world of AI in healthcare means for professional and personal identity of clinicians. Because everything is changing and it's changing very quick. And what does that mean to how I see myself as a clinician and the role that I play and the worth that I add? Well, last story, and it's also an AI story, George. The cost of not using AI. So, as we experience in real time at what feels pretty much like warp speed, the AI-induced changes coming to healthcare, I do expect that we'll see a rise in expectations in the community that clinicians are using AI to support their clinical work. But will we also see medico-legal drivers and eventually practice requirements to use AI? Personally, I do think that'll happen. I'd like to think we're 5 or so years away from that, but maybe not. England's health ombudsman has called out recently repeated failures by humans to accurately interpret CTs, X-rays and other medical scans, which has led to some big cases in the UK of not just avoidable delays in diagnosis, but avoidable patient deaths. This includes not just doctors failing to spot abnormalities in scans, but also delays in the system, which means scans aren't performed in a timely manner and results not being followed up properly. At the hackathon, George, one of the GPs was telling me about a case that he knows of where a GP was sued by the patient because the GP failed to ensure that this patient actually saw the specialist he was referred to. And now the GP is being sued. Now, if AI can help with diagnosis or indeed maybe be better than humans at it, and if AI can also help with care coordination, patient follow-up, etc., what do you think? Do we see a time where the use of AI is actually mandated in the name of patient safety?
Whether it's mandated or not, I guess, is a policy question. But the reality is any good clinician should be willing to use the tools at their disposal to make their job better, improve quality, improve safety, improve efficiency, improve effectiveness. So the fact that some clinicians choose not to use AI purely because they see it as a threat is part of the problem we discussed earlier, where we had this AI versus doctor debate. The reality is, if you have a tool at your disposal, I mean, I remember when they first brought out an electronic version of MIMS. So MIMS is the reference we use for drugs. Back in the days, we used to have to flick through a big book to find the name of a drug and what the dosage it came in and how to prescribe it. In the late 1990s, MIMS came out on a Palm Pilot. I remember pulling out my Palm Pilot at Royal Prince Alfred Hospital and having 10 doctors come around and going, oh, wow, what's that? And yeah, within weeks, they were all using the same tool. Access to the tools is one challenge. You have access to those tools. Failure to use those tools, to me, suggests negligence. If you have a tool available that's going to provide you with higher quality, safer care, you're not doing your job. And the aphorisms of Hippocrates tell us that we first do no harm, but we have to have focus on the good of the patient as our primary concern. So I think ideally my clinical colleagues would join the journey of AI and start using it. And to be honest, whenever I catch up with a bunch of doctors, we all talk about AI. So, it is top of mind. Most sort of come into grips with it. They're learning. It's a learning process. And I think our educational processes are going to need to improve. And it is a challenge because AI seems to be exponentially improving every couple of weeks. So keeping up with it's not easy. But I think what will drive this will be the first legal case where someone didn't use AI and there was a poor outcome. And it's the same sort of way when we did this with informed consent. Informed consent didn't become a thing until an ophthalmologist got sued for a couple of $1 million because they didn't do it properly. So unfortunately, that may drive the behavior, but I think maybe the profession itself should start mandating its use and educating the sector about its use.
Yeah. It's a really interesting perspective because a lot of the people who are more skeptical, let's say, and rightly so, about the use of AI, it is because of an ethics, patient safety lens. So the fact that we can also turn that on its head and say, well, actually, for safety, we should be using these tools. But I think there does need to be some validation and evaluation of those tools. And the literature is increasing every week on how we evaluate these tools because I have no hope that we're actually going to regulate them. Thanks, George. Always informative to chat with you. Well, it's time for a quick break, and when we return, we will be talking personal data stores with Janette Hughes.
Looking forward to that.
Today on Pulse, we are joined by our very first Scottish guest. Janette Hughes is the Director of Planning and Performance at Scotland's Digital Health and Care Innovation Centre, which is known as DHI. She's been working at the intersection of public health, innovation and digital transformation for years, and she's someone who really understands what it takes to design health systems around people, not just policies or technologies. Janette is very passionate about how digital tools can give individuals individuals more control over their own health and care, driving effectively more personalised, equitable care systems. Janette and I were hanging out recently in the UK and discussing some really cool topics. And I was like, Janette, you should come onto the pod. And she said yes, and I was very pleased with that. So welcome to the Pulse Pod studio, Janette.
Thank you, Louise. It's lovely to see you and George again. And yes, it is sunny here in Scotland, so delighted to be here.
So, Janette, we always like to start with our guest's personal journey. So let's start with your story. How did you get involved in digital health?
Well, that is an interesting story. Starting at probably the kind of beginning of my academic career, I actually trained to be a designer. So it was like spatial design, working with architects. So nothing to do with technology, nothing to do with health. And actually, it was when I was in your country of Australia that I started getting involved in digital, because I was backpacking around Australia. I actually worked for 6 months with Telstra, and that kind of opened my eyes into communication and technology. That was 1995. So there was no mobile phones. There was no email. There was nothing like that. But I started to understand from Telstra's perspective how technology might have a position in the future. So when I came back from my backpacking journey, I actually got to the UK. I had a first class in design, and I thought, what am I going to do next? Opened the newspapers, and this was 96, 97, so it was a bit of a recession. And all the jobs were facing towards software development, technology. Not that I understood what that actually was, but I thought, do you know what? I'm going to get a graduate job in technology. So I did. And I worked for an American software house. I was based in London, and I did that for 3 or 4 years. And then I came back up to Scotland, and I thought I better actually get a technology degree so that I know what I'm talking about. So I did my technology degree, and then I went into innovation and economic development. I did that for probably 3 or 4 years and understood how businesses worked, understood the innovation cycle. I used to advise businesses generally on e-commerce and things like that, which was the early stages of 2000. I then actually developed a proposal for the first Wellness and Health Innovation Centre for Scotland, and that was 2006. And I ran that for 4 years before I was kind of headhunted into the NHS to run their big programmes. So I'd worked with industry. I then worked with the NHS, and I ran big major programmes in the UK, but with a Scotland lens. I did that for probably about 5, 6 years, and then ended up going into the academic world, doing smart city, but still health and care. And then I found myself back in the digital health and care world with my old boss and chief exec of the Digital Health and Care Innovation Centre that I've now worked for the last 8 years. So for the last 17 years, I have been involved in digital health and care. So I can tell you it's been a very exciting journey, but quite frustrating at points. So I'm delighted to be sharing this story. And I'll probably weave that into some of my answers today.
Oh, that's cool. We often say, in digital health, we don't just share common passions, we definitely share common frustrations.
Indeed.
And we were fortunate enough to have you down here in 2015 as one of our ITAC keynote speakers, I remember. So that was quite an interesting journey. And then we caught up again a couple of years later in Barcelona. So it's great to see that the same people are still trying to solve all the problems, eh?
Indeed, George. We will get there.
Yes, we definitely will. And so for our international listeners outside of Scotland, what is the DHI, Janette, and how does it operate? What's its role within Scotland's health and care landscape?
Scotland is fortunate enough to have a national digital health and care innovation centre, so that is the DHI. We're funded by Scottish Funding Council and Scottish Government, and really our job is to make our partners ready to adopt digital. So we work with the NHS, we work with local authorities, we work with the third sector. We also try to encourage the academic community to either do more research in digital health and care, but in particular to make sure that we have the right skills. So we try to influence the curriculum at university and college level so that the right people actually come out the courses with the digital skills to be applied. So that's really our job in essence. And one thing I would say is, even though we're the Digital Health and Care Innovation Centre, All our work we do is co-design. We believe that bringing kind of 3 strands of innovation together will actually get us to adoption and scale. And those 3 strands is technical innovation, service innovation, and business model innovation. Often the forgotten part of actually how digital services get put into service and get scaled.
Cool. So moving on to today's topic, personal data stores. Sounds like quite an intriguing topic. Can you explain to us what a personal data store is?
So this is something that we've been working on. As I said, we do co-design and have done for the last 10 years. And about 3 or 4 years ago, what we were realising is there was a common theme when we spoke to citizens and practitioners. And that common theme was that there was a lot of duplication, a lot of repeating of the same story, repeating it to 15 individuals on your journey to care. And that led us to look at not just what citizens and practitioners needed, but actually could patients and people hold their own data? We do research and development, so we moved to testing that kind of principle. Could we actually develop a personal data store that the person held? The concept of this is very much grounded in the social determinants of health, and that when you go to the doctor, they only see about 30% of your data.
Where does that 30% figure come from? Because that seems quite low.
Yeah, I mean, that is in many kind of peer review literature. If you look at the social determinants of health literature, that 30% of data, because if you think about the other data sources, Louise, it's your environment. Where do you live? Are you connected socially? What's your social connections like? And what happens is when you go to your GP or your hospital, they see 30% of that clinical data set.
Yeah, that's right. So they're just looking at clinical data, my knee is sore or I've got this disease or this diagnosis, these are the pills, but it's not in the context of the world that you live in and what's important to you.
Precisely. And you don't often bring your complete lived experience and your backstory unless you actually verbalise it. And as we know, time is of the essence with clinical contact. So you only have 8 minutes to tell them a very rich story, and actually all they see is 30%. So that was really where it came from. It was really coming from 3,500 people telling us they did not want to repeat their story. So a personal data store allows you to build your story, and you keep the story and you share it with whoever is important to you. So that might be your doctor, also might be your neighbour, because they might have to look after you later on, or it might be your social care provider. So it's really putting power back into you as a person to hold your own data and change that data as things change for you.
Oh, absolutely. We're really big fans here at Pulse Pod of empowering individuals with giving them access to their own information. But it surprises me that still in 2025, that is a contentious opinion. I was at a hackathon all weekend, Janette, and you've got clinicians there who love this stuff. They've drunk the Kool-Aid. They want to change the system. They're really innovative. Everyone shares similar values. And I still found myself having a conversation with the doctor going, oh, but people shouldn't get access to all of the information. And I'm like, okay, let's have that discussion. So the work that you guys are doing in personal data stores, and that's obviously incredibly different to how data is managed now in the NHS Scotland and other healthcare systems. So what sort of difference do you think it could make for patients to curate their own information and decide who gets access to it?
On both sides, productivity is going to be a big gain because, again, that repetition from the clinician's perspective, and again, there's a lot of administration within health and social care of them collecting the same data over and over again. So that burden for health and care practitioners could be stripped away, and they could actually be having a much richer conversation when they meet the person. So that's a benefit. But the other benefit is the ability for the person who holds that data to share that data with their circle of care. So if I think about my dad, he had dementia. My mum was looking after him. He got often called for tests and having to go to whatever examination or meeting with his clinicians. And a lot of the time that would come in the form of a letter, and that letter might not have been opened, etc. Or me and my brothers would have to actually enable my mum to get to the hospital. So that sharing of data, and actually that has a positive effect on the family because they're better versed on where my dad is in the journey of his health story. And we're also empowered to plan better. And that actually might take the burden again of the health and care service because more can be done with the carers around that person. So that is a benefit. We also see a benefit from an administration point of view. So we've used personal data stores with health and social care where we can actually self-referral because you're building that story, and that starts to verify that actually you might be entitled to go into the third sector and actually get a service. The data can be transferred automatically, takes the burden off the service that the person is being referred to.
One of the very first projects I got involved with back in the early 2000s was a personal health record project. We were looking at it very much from a technology perspective, the shoebox of all the data. But one of the things we found very early on in that project is that by putting the person in control of their information, they became more enabled and much more willing to engage in healthcare. I was trained in the old school of medicine where I, the doctor, treated the patient, but all of a sudden we started getting this idea that we were on par and having conversations around the same data. And the fact that they controlled the data was interesting. So from your perspective, what difference does having a personal data store make for the patients? Does it change their mindset about how they interact with the healthcare system?
Yeah, I think it allows them to realise, depending on what they're doing personally, and again, this goes back to the kind of social determinants of health, how that has an effect on their health. So, for example, we're running a project with the personal data store and weight management, and we've also ran one with COPD. Now, what people realise is, for example, if they've got early diabetes, if they become more active, they start seeing their blood glucose go down. And they start seeing the correlation because sometimes that data was hidden. So they weren't realising that if they went the walk, those things were having an effect. I also think it empowers them to have a better conversation when they get to the doctor. So rather than just repeating the kind of benign, high-level stuff, they can actually get into the guts of what the problem is and how they could self-manage on their own terms. So I think it really empowers the patient, but I also think it empowers the clinician to have that better and more rich conversation, and with their carers as well, because the carers are actually seeing a better data set.
When I was in San Francisco in 2004, I met Dr. Tom Ferguson, who was one of the early champions for patient-enabled records. It really is a socio-technical thing where we can provide them with a tool that enables them to play a greater role in their own healthcare.
Absolutely.
I know you travel a lot for work outside of Scotland as well, Janette. So have you got examples you can share of, even if it's pilot projects, whether it's within Scotland or in other locations, where these ideas are being put into practice?
Yeah, I suppose the ones that I know more of is the ones in Scotland. So I touched on weight management. The other one is COPD. And really, we were doing a project with one of the biggest health boards during COVID. And the question was, how do we keep COPD patients out of hospitals? So we worked with the clinicians and their patients, gave them Fitbits and other devices, and allowed them to start recording their clinical data better, and obviously pushing that into the hospital environment from their home environment. Now, what that allowed the clinicians to do was actually feed that data in so that they could start seeing the people that might go into a crisis mode in the next week or so. And then preempting that by sending that community nurse to the home to intervene so that you don't end up in hospital. Let's give you antibiotics now. And actually that led to a 50% reduction in hospital admissions during COVID for COPD.
50%?
50%.
Wow.
That was really key at that point, but it just showed that it could be done. And the interesting thing was, because it was an R&D pilot, the patients didn't want to give it up. So when it came to the end of the pilot, they're like, no, I really want to keep this because it gives me a better understanding of what's actually happening and what the triggers are in my life that actually lead to exacerbations of my disease. So that was a really key point from an international perspective. We do think we are pioneering this concept in a way, but we learned from other international states. We actually got this whole idea originally from Estonia, who were leading the way probably 5-10 years ago. And I've got the Estonian government actually coming in this afternoon to the offices. So they were leading the way. They had kind of bucked the trend with digital, and they showed us a blueprint that we should follow. We've probably now evolved that to a different level, and possibly maybe they're coming to learn a wee bit about where we've got to, building on their learning. I think also the Nordic countries do it very well, where they've actually given data access and more freedom to patients to share that data set. So we're very much learning from that Nordic corridor, I would say, Denmark, Finland, and others, on how to move and shift the balance of care using data.
Great to hear that having access to the data has actually changed people's health behaviours. That's incredible. It's just such a no-brainer, really, to empower people to own and manage their own data. What are your thoughts around trust for personal data stores to earn and keep that trust?
I think that's a great question. I mean, obviously, trust has to be earned, and trust has got a relationship with benefit, because all of us as consumers will certainly give people data if we get enough benefit back. And I think that's seen in some of the applications you probably have on your phone. From an organisational perspective, what we've found, again, through our co-design, is people are nervous about giving their data to big governments and corporate organisations, especially when it relates to health and care. The projects that we're running from an R&D perspective is actually we are working with a community interest company who then will never sell the data. The data is locked and the data is with the person. So there's different constraints. It isn't a profit-making organisation, and it has a different kind of construct to obviously a government holding the data, because I think the problem with data is that patients and the people that are collecting that data might feel that the kind of big brother approach is happening, and they'll be a wee bit nervous about sharing that data. So we've very much gone for this community interest structure. We've very much gone for the patient holding the consent, so they can switch it on and they can withdraw that consent at any point. That gives them the comfort and confidence that they can curate their own data, but they can also control that data and control who they share it with. But remember, this is still R&D at this point. Encryption and cybersecurity, there's lots of things that we need to consider, and the organisations also holding the data. So I wouldn't say that we're at the end of the road, but we're certainly on a journey to make sure that trust is treasured and that relationship with the data and the patient and organisation that is keeping it safe.
Looking at the technology component for a bit. So back when I first started as a doctor, we used to tell patients to keep some sort of medical record in their handbag. When we had a high-risk patient, we said, keep a list of your medications, your allergies and your diagnoses on a piece of paper and pull it out when needed. And then we moved to a USB stick, and then Microsoft came along with Health Vault, and that came in and out of favour. And there's been all sorts of things. And here in Australia, we have My Health Record, which is a national personal health record. From your perspective, is this a cloud-based system? Is this a card system? There's so many different ways you can manage the data.
This is a cloud-based system. It's interesting that you talked about the evolution of collecting and curating data. In Scotland, when you have a baby, you have a red book, and you actually collect the data in the red book, and the red book sits in a cupboard and comes in and out the cupboard as you go and see your nurse with your newborn. And that was pretty effective because everybody knew what it was, everybody could find it. We don't have that within the personal data store. It is electronic, is cloud-based. And I think one of the challenges, and this comes across all consumer applications as well, is the password and trying to make sure they remember their password, because that unlocks everything. So we have actually a paper record to say, write your password down, put it somewhere really safe, because that will unlock it. And it will only be you that gets access to that. So even the community interest company will not know what that is, the way the architecture's built. So I think that's actually one of the challenging parts, but it's also one of the kind of safest parts as well, so that they actually feel that they're in control and can keep that for their own use.
Well, it's interesting. Sometimes you have to go back to the good old pen and paper to make things happen.
Absolutely.
Yes, yeah, pen and paper. Okay, we won't title the episode that, but it does have a role.
Let's not go back there.
No, God, no. Janette, earlier in the show, before you joined us, George and I were talking about 23andMe and the fact that they're now bankrupt and the liquidators have moved in, because now the millions of people who've given their data is the assets are going to be auctioned off to the quickest bidder, probably. Having personal data stores, does this solve some of those dilemmas about when we give our data over to whether it's corporate or government, that we maintain control of it regardless of changes in circumstances?
Yeah, well, we believe it does. So it really puts the person at the centre of interoperability, because you have the data and you can choose to share it and you control it. Again, coming back to the construct we've chosen about the community interest company, it's not a company that owns your data. As we all know, and I think a lot of people outside the clinical world don't realise it, actually it's the clinicians that often own their data, even if it's my data. So, there's, I suppose, misconceptions of who owns data in the clinical world. So yeah, we believe that data will be richer and be better controlled. And again, safeguarding, shocks in the market, because you have the data and you have access to that data piece. But we're still testing all of that out, Louise. I suppose that I need to caveat that this is research and development. So we do not have all the answers, but we're on a journey that we're really happy to share, and we're learning and we're iterating.
So one of the challenges we've had here in Australia is that a person can have their own record, which they build up, but often a lot of the information comes from clinicians, and clinicians have been less than forthcoming in sharing records with the patients directly and allowing them to integrate it into their records. What are you guys doing there around getting clinicians to buy into this idea and to actually share their information? So how do we get clinicians to share data more effectively?
Yeah, I think it comes back to the person. So if you're always entitled to ask for your own data, it's never an easy process, even though it's been written into legislation and terms and conditions. Once the person has a personal data store, and the personal data stores that we're building initially are not clinical. So they are, what's your name? What do you know about yourself? What's your family structure? If you go into hospital, what do we need to know? Have you got a pet that needs to go somewhere if the ambulance turns up? So it's less sensitive data. But what we're trying to do is layer that data set. So as they get more familiar with their personal data, when they do go to their doctor, they can ask for data, and then they can store that data back into their personal data store. Now, the clinical record will always be there. It'll always be owned by the clinician. So it's about picking the right information back into your data store that's actually going to make a difference to you managing your own health. So that is one way to do it. The second way is to show benefits to, for example, primary care. If they see a benefit, if they share the clinical data, that they actually then have the patient more empowered to go and do more for themselves. So we're working with GPs up in the north of Scotland around that. Now, that project, we're looking at weight management, so sharing data about diabetes or pre-diabetes information that could go into the personal data store. We are also getting data in. Sometimes it's coming in PDF form, but again, we need to get better at that. We're also working with others about APIs between the personal data store and clinical records so that we can get that link automated in the future. So again, there is work happening, but we see again the person being the holder of that data. And if they're asking for the data from the clinician, that data should be forthcoming.
One interesting initiative here in Australia has been the share by default. Pathology labs and radiology labs have to share data with the patients. I think that's a driver, because I don't know what it's like in Scotland, but even I as a doctor struggle to get copies of my own pathology results and radiology results.
Yeah, and that again comes back to the point, when letters are sent, can we get a copy of the record, and can the copy of the record go in the personal data store? And that means that it's not just like if my dad, who obviously had dementia, he could then share it with his family if consent was given prior to him getting dementia, which would be a lot easier for the family to manage, but also a lot easier and less friction between family members and the health service in trying to get access to the right kind of care.
Janette, what, in your experience, are the biggest barriers to seeing personal data stores become mainstream? You're obviously doing a lot of research and development on making this happen. How can our listeners get more involved, think more about this, see what we can collectively do to make this happen?
Yeah, I think it comes back to trying to get really rich use cases that is showing that there is benefit, and not just benefit to the person, the patient, but benefit to the whole system. So that's really what we're building. We're always looking for partners internationally to do twinned living labs and twinned research. So absolutely, if anybody's got an interest in this area or they're doing something similar, maybe a different approach, we're really keen to reach out and learn from others and collaborate with others, because as we know, this is a global challenge. As I say in a lot of international presentations that I do, most strategies around the world talk about shifting the balance of care. Even the Americans are talking about it. However, to do that, data is the enabler, and it's not just clinical data. So if anybody's interested in social determinants of health, personal data stores, empowering patients to do more, then we are very much open for business in Scotland. And we'd be delighted to partner and share our learning. And that won't just be good learning, that will also be the warts and everything, which I think we don't do enough of. So I think we need to share not just the success, but the failures and the bumps along the road.
Yeah, what are we learning from it? Absolutely. Well, we'll put links to your LinkedIn profile, Janette, and DHI's details in the notes for the show as well. And yes, encourage people who are interested in this, reach out to George or myself or Janette either way and see how you can be involved. We're big fans of getting information into the hands of patients. Janette, thank you so much for spending some time with us today. It's been great having you in the Pulse Pod studio, and I look forward to doing whatever we can to support the development around personal data stores. So thank you.
Thank you so much.
Thanks.
So, George, we've come to the end of yet another episode. It's episode 22 already. Amazing. Do you have any recommendations today for the Pulse Poddies?
Well, yeah, I've just started reading a new book, and I thought the title of this book is intriguing. Technology is Dead, The Path to a More Human Future, by a guy called Chris Colbert.
Oh, I like that title.
Look, so it sounds like a Luddite's Bible, but in actual fact, Chris Colbert was in charge of the Harvard Innovation Lab, so he's not a Luddite by any means. But what he does look at is how we need to think about technology and its role in the future, and stresses the need for a continuous action, experimentation, and learning model so that we continue to integrate technology into our lives, but in a humanistic way. So it's an interesting read. I'm about halfway through. He's had some great examples of, where technology has gone wrong, and because we focused on the technology, not the usage models, and that's some interesting discussions there. But it brought to mind that that famous quote, and it's attributed to Abraham Lincoln, but I'm not quite sure whether he said it. And he says, the best way to predict the future is to create it yourself. So again, it puts the reality in our own hands. We need to recognize how we're utilizing technologies to their best, and not just assume that technology for technology's sake is the best way forward. So it's an interesting read. I'll let you know when I finish it whether I do think technology is dead. I'm a bit of a technologist, so unlikely for me to go down that path, but maybe I'm becoming a bit more humanist as I get older.
Okay, we'll have to change the topic of the podcast then if that happens, George.
Sure. What about you, Louise? What recommendations do you have for us this week?
Well, I also had a book recommendation. So I've just finished reading Careless People. I did the audiobook version because I've spent a lot of time in planes recently, so I was able to finish it all in a week. So Careless People is by a woman called Sarah Wynne Williams, who's actually a Kiwi, and she worked at Facebook on global affairs. She basically begged and did everything she could. She tells the whole story of how she got the job there because they didn't think they needed someone with her sort of skills and background. Her book is a memoir, and you might have seen it in the press because Facebook Meta have done everything they can legally to try and prevent its publication, which is, of course, the perfect example of what not to do when you handle a corporate crisis, because now everyone wants to read the book because what's in this originally?
She probably should thank them for the advertising.
Yes, I'm sure she's sold a lot more copies. The book is interesting for those interested in the topic of how social media has impacted and is impacting purposefully global politics, our mental health and well-being, purposely causing us to be one-sided and misinformed and all of these sort of things. It's a really damning indictment, this book. It is written as a memoir, so it's very personal. So I didn't learn a lot of new things except for the personalities. So she spent a lot of one-on-one time. She was very senior with Mark Zuckerberg, Sheryl Sandberg. She pretty much has nothing nice to say about them. And some of her stories, I can see why they did not want them out. But I was reflecting on the other Facebook book I read a while ago, which I think was better, which is An Ugly Truth. And that came out in 2021. And it was written by journalists Shira Frankel and Cecilia Kang. That was an eye-opener, that book. Really scary. But I guess to read Ugly Truth and to know more about how Facebook operates, but written by journalists, and then to read the memoir by someone who, if you believe what she says, she was in the rooms, and to see the evolution in thinking of Mark Zuckerberg and how he and the company has become what they've become now is interesting to people who look at the future of social media and the impact it's having on our lives. So that was my book recommendation for the week.
Well, that does cross over because the book I'm reading uses social media as one of those key examples of technology for technology's sake overriding, the human requirements. So I think we need to mold the two together. Humanity and AI together turns us into a better version of whatever we are.
Yeah, no, that's right. And that topic is, of course, everywhere because of adolescence as well, the Netflix show. Have you seen that? It's done so well. Like, technically, it's brilliant. There's only 4 episodes, and each episode is a single camera shot. So after I finished watching it, I was like on YouTube looking at all the behind the scenes and like, how did they do this? The people who put that show together, and one of them stars in it, and he says that the reason they wrote this show and did it the way they did was to show the impact and try to understand how this happens, that young people can be radicalized when they're parented by a community of people, of strangers on the internet. And I remember, George, years ago when your kids were a lot younger than they are now, visiting your house, and, you had computers everywhere. Everyone's got a computer. They were all in the living room in that like open area of your house. And I remember asking you about it, and you're like, no, I spend too much time in Silicon Valley. I know better.
It was an active decision we both made, that we not so much to monitor, but to just be engaged with what the same thing they're engaging with. So to understand where they're involved. And again, they've all got independent minds. They make their own decisions. But I think as a parent, we have some degree of responsibility to do some surveillance and just be engaged in it. And it points out, whilst we've highlighted the great things that have been given to us by technology, there is a dark side as well. And we just need to make sure we at least understand it and understand what the drivers for it are. And hopefully in the future, manage it a bit better.
Yeah. Oh, and I just wanted to give a shout out for our Australian listeners that are based in Queensland. So this is very specific, and in regional Queensland, there is an Allied Health grant, and it's a grant up to $10,000 for allied health professionals to enhance their digital health capabilities. So it's an initiative that the Northern Queensland Primary Health Network is doing, which is really cool. So I just wanted to give a shout out to that, and I'll put a link in the show notes. So if you, listener, happen to fit the eligibility criteria, or you might know someone, I think you've got until mid-April to apply for that grant. So, always, we said last episode, George, allied health is hot right now. Yeah.
Absolutely.
Here's another reason for allied health to get more involved in digital health. George, so cool catching up with you today. Thank you so much. If you could read us out, please.
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcasts. And don't forget, you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive digital archive. Send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. Thanks, everyone.